Θα ήθελα και εγώ να ευχαριστήσω την Οργανωτική Επιτροπή και κυρίως τον Σωτήριο, ο οποίος θα επιστρέψει, αλλά θα μου επιτρέψετε η παρουσίαση να γίνει στα αγγλικά, καθώς έχουμε επίτιμους καλεσμένους. You heard this topic many times. Hopefully it's not going to be a platitudinous one. I'll try to make it a bit lighter. This is our enemy. You can see various morphologies. And this is what we've been doing all these years. It started, the innovation that started in the 60s, just went up for a decade. And the only difference that was made was in the late 90s when the pure carbon was used. This was the enemy to fight surgically. And also for the tissue valves, you can see all these tissue valves here, and all the treatments that we use for these tissue valves to attack certain molecules. And for instance, you can see the last one, the MitraFlow, had lots of, I would say, adverse publications because it was the previous model that didn't have any treatment at all. The new one has some antiphospholipid treatment, but no anti-calcification. So it's more or less, we haven't done that much on that front either. And this is the new ones. Again, more or less the same concept. Again, they're stuck on stents. Maybe the stents are more flexible. Maybe they're not made purely from a metallic thing and they're moving a bit. But again, the concept is the same. And the valves you talked about before, again, they're stuck on stents, and one of them was taken off the market. And of course, the results are very good. I mean, we've been doing all these things. You can see all these graphs, either for the metallic valves or the tissue valves. But is it true? Do you know what is the chances of somebody who is 40 years of age to have an operation, to have an adverse event in 10 years? It's almost 1 in 4, and has also a chance 1 in 10 of dying in 10 years, even less than 40, just having a metallic valve. The same thing happens for the tissue valves. They say that the tissue valves, from all the data that we have, they last for, maybe for patients that are over 70, they have a freedom from SVD, maybe 30% in 15 years. But we'll see that later. Maybe it's not exactly like that. And, but we have to compete with this one. This is real-world data, and we have to be more or less competent with that. And I'm just presenting you briefly, I had randomly some of our recent cases here. You can see the results are more or less of what it is in your hands for these isolated AVRs or even the combined ones. But then again, 30 years ago, this came up. It was a young registrar 30 years ago that had this idea, sold it for peanuts, and then after that, it just went rocket high. And everything as an innovation, it starts and ends to a model that doesn't look like a leg, but it's extremely functional. It's very good. And that's what happened. Now, that was from 2016. Maybe now we're more than 250,000 implants worldwide. And the estimate is that probably the TAVI in 10 years will be what we have so far. So we have about 300,000 cases per year globally. And of course, one of the reasons is that the patient's aging as well. You can see that's from UK, where the ladies are doing much better than men. Maybe the life expectancy will go almost to 90 years of age. And of course, Germany, who's the champion, has been doing most of the TAVIs worldwide nowadays. And certainly in Europe, you can see that what is the trend like? The surgical, it's gradually diminishing, but it's the TAVI ones going up. And of course, if we rely on the quality criteria, you can see that it's first choice. If you can see it, and the same thing happens maybe in Switzerland, in some other countries, not in the whole of Europe, certainly not in our country, but you can see that for the surgical recommendations are much less. And of course, why not? This is 33, it's a massive number. 33,000 patients at the Gavi German trial, they did very well doing TAVI. You can see that although the risk profiles are slightly diminishing, the mortality is getting much better over 5 years. So why not? Why not do it? And of course, there's something else as well, something that I would say to Michael, that you don't have to fight Michael, the cardiologist, you have to find the industry. That's the difficult thing. And of course, we don't know if it's the best treatment, but Certainly it's the best with the DRGs. So the indication goes higher, and you have a valve that costs 24K, and on the other hand, you have a valve that costs maybe 1K. It's a big difference. And you said that a gentleman said that before, I can't remember. The surgeon is not the one that deciding. There is always a gatekeeper, and you know that the common denominator in this case is most of the time the cardiologist. And we agreed so far at the beginning that, okay, it's high-risk patients, inoperable, or what we used to say ages ago when we had the chance to say, no, I'm not going to operate on this 80-year-old. It's rubbish, it's not good. But when the TAVI came up, we started saying, oh, why not? I will operate on this patient. And of course, that was a statement. TAVI, it's only for very or inoperable patients, and it's not for intermediate risk patients or even for high risk patients that can be operated. That's it. But, and this was at that time the guidelines, but now the guidelines have changed. I think Nikos is going to talk to us about that. And now what we had before as an indication of 2A, now it's 1. And what we had nothing before is 2A regarding the intermediate risk patients. So things are changing very fast. 2017. Of course, all this thing was based on these studies. They were very nicely done studies, assumingly. They were RCTs. One of them, the last one that had lots of criticism, we'll talk about that. It was the propensity match. And of course, they relied on, all of them showed that the TAVI is, if not the same, certainly not inferior, and maybe it's better. And that was, for instance, for the intermediate, for the PARTNER 2 trial. But is it really true? Because these patients, you can see that one in every 4 patients had a previous coronary bypass. And you wonder, and you say, this is a TAVI protective case. How on earth a surgeon can randomize his patient, can participate in a study that on the one hand will have somebody who is competent, will have a patient with patent grafts and will stick a catheter to the valve. And on the other hand, you will have the surgeon that does the same thing on a patient that has patent grafts, has to open and operate on them, and some of them even will be forced to put a small valve. So this where you have somebody to consider all these things. And of course, this is the famous propensity match trial, and I think that it's Nikos, it was co-authored the flows in this presentation, and of course they were biased. There were some in the PS algorithm, the propensity score algorithm. There were certain things that were not included. I don't know if you can see it clearly on the third one. You can see that the risk profile between the two groups was, in one was 5.4 and 5.2. Somebody would say, oh, it's not a big deal, but there was significantly different. And of course, they never thought of including patients with with mitral regurgitation and of course with low ejection fraction, which from our knowledge, from clinical issues, we can see that it makes a hell of a lot of a difference. And of course, they were not balanced. You can see that patients, they had concomitant operations that was not taken into account. And overall, as a conclusion, you can see that it wasn't as strong as we all thought. And of course, that's true. That's true, because you can see this thing. This is, let me put it politically correct. I stole it from Joe Kempfert. It's a very nice slide showing that, of course, in real life things are much difficult. When you have patients participating in a trial which is well-selected patients, they have less mortality. But if you go to the real world, you expect the mortality to be higher. This is more or less what happens. But and of course, this is what James Fox said. And it's true. The RCTs, which is supposed to be the holy grail of our science, it's very good for certain, say, medical aspects. But for surgical ones, somebody has to consider how can you control all the variables linked to a surgical operation when it's been done by 2 surgeons by different institutions. So somebody have to reconsider whether RCTs really in surgical. In the surgical field are as strong as they say. And of course, what does it mean? That we will stop trusting them? I don't know. There is a self-criticism by this lady that just questions the quality and the value of the guidelines. And of course, this is a dictum that we have to follow us. It's always doubted, of course, scientifically, what expert says. And of course, somebody would say that maybe in these situations, we can see the tough cases. Is it TAVI better? Probably not, except the last ones, that things are improving very much, the valve-in-valve, and it's the cases where really the surgeon wants to get rid of the patient. And that's what we thought. But if you just put a valve crimped in, probably the shape of the valve will change. But it's not the case anymore, except these small-sized valves when you're pushing yourself to put another TAVI. Yeah. And of course, these are the good standards that the operation does very well. The complex cases, of course, the conventional surgery does very well. And there are conditions as well that the TAVI does well, of course, provided that really you can find which ones to avoid and which ones to choose. And now, again, I think that Nicholas will talk to us about that. Now that the new guidelines are appearing, you can see there that it's what influences the decision now has to do with the morphology of the valve. That makes that guide us will guide us towards an unfavorable morphology will guide us towards the surgical aortic valve. What will be the wish list? What would you like to have? Suppose you want to have a TAVI. You want an easy insertion, you want a flexible valve, you want a valve that you can take it in and out, something to show you exactly when to land the valve. This is what we would like to have. And we didn't manage to have that, or maybe they didn't because it was a cardiology invention, it was Laos, with the foundational initial devices that I was involved in as well. And then came, of course, the new series. It's much smaller, they are more versatile, you can just, they are retrievable, they're repositionable, it's much easier. And of course, there are certain issues that will continue being. For instance, it's when you have when you do a mathematical model, you find out there are certain areas of stress on these valves. And of course, you may pay it in the near future with the early SVT of this valve, especially when you start applying that not to low-risk patients, but to low-risk young patients. That makes a difference. And for instance, you know, this was a paper that came from Canada, and we say that after 5 or 6 years, maybe these valves are degrading. But what about the xenografts? We all say that, oh, don't worry, we'll use a xenograft, and probably in 10, 15 years, you may need another operation. If we continue using as a surrogate of SVD, the reoperation, yes, but that's wrong. We cannot consider that. And of course, it's, we don't have follow-up data, so we don't know. Doesn't mean that a valve, that it fails when you reoperate on this patient. Maybe it's much earlier. And regarding the famous paravalvular leak, of course, it matters. And you can see, for instance, the valve does not sit that well there. It's a hostile route, and you can get the paravalvular leak, and they find that even a mild paravalvular leak can cause trouble. And then what about the neurologic complications? It's 1 in every 5 patients, they may have some sort of a neurological impairment. And not only that, but it's, you may also get a subclinical leaflet thrombosis, and we assume that this has probably to do with the fact that the motion of the valve is not that good. That's why now the new recommendations would be to start them on anticoagulants, much better results than asking them to have a dual antiplatelet. And how do we define that? Now that we are more clever, we see things, we can detect subclinical and silent brain infarcts. You can see things like that. And of course, with the new devices that cardiologists use, or the users of the TAVI use, with certain filters, you can see that you can get better results regarding these silent problems. And now in the real world, of course, with all the new devices, things are getting better. And it's real-world things. And with the new valves, you can see you still need, of course, some pacemakers. And the more the valve aids you not to have a paravalvular leak, the more the chances to have a pacemaker. This hasn't been solved yet. And of course, you don't have major complications. When we started, I remember that with these 30 or 32 sometimes catheters that we use for the groin, sometimes you will pull it out and the whole iliac artery will come together. You don't see that anymore. You don't even need a vascular surgeon to be on the side when they do these cases. What about the future? What happens here? Is that where we're heading? Because we just left the high-risk patients behind. And that's what we thought some years back. No way, low-risk patients, forget it, only surgery. But is that true? Look what's going on. These are the new studies that will be going. And if you look at the last one, the NOTION study, you can see again, it's a super selective. It's not all comers. You can see only 1 in 6 patients could be selected for this group. It's super selective. And that give you some questions. Of course, will be developments and will be more developments that we cannot figure out right now. And our final thoughts, what would that be? Where are we heading? Are we going to the intermediate surgical risk patients? You're going to younger patients with low risk? Are we going to patients with moderate stenosis, with heart failure? Or sometimes even asymptomatic patients that have severe AS as preventing in order to avoid a decline in the cardiac function, which is it's imminent. And at the RAS meeting, that's what Thomas Walter suggested, who's been in the business many, many years, said, if you are as a surgeon, you want to do that, you must get interested, you must be involved, you must do everything, provided that the host will allow you to do that. As you said before, the cardiologist should allow you to enter their place. Unless you are in an establishment that allows you to have your own practice, as they do in Munich, as they do other places, I don't know if you do have that as well, to have your surgical service that does TAVI. But it's the way to go, and I agree both with Dr. Dikas and yourself that that's the way to go. And I think it's going to be unbeatable. And of course, as you can see, that poor surgeon there, of course, don't think that it's trying to fight the avalanche. I think that it's trying to roll with it. But don't worry, whatever happens, we'll always have something to do. Thanks very much.
Thank you, Dr. Stavridis. I think most of us couldn't agree more with you. Anyway, are there any questions from the floor? Yes, please.
Sorry.
There was a meeting there's an annual meeting in Rotterdam of the German chiefs, and there was a discussion where to go, and TAVI was of course a big issue. You know, TAVI in German medicine in Germany is a business. In Austria, for example, it's a social donation of the patient. So different. And then there was the discussion who should go into the TAVI. Then there was, okay, the best young surgeons should go into TAVI. Then was the next topic was heart failure. And then I asked, now, sorry, we have discussed who should go into heart failure surgery. And then there was oh yes, the best young one should go into heart failure. There was a discussion on aortic aneurysm. And I said, okay, growing market. And they all looked on it as a potential market because it's their business. They're living from it. And then they said, okay, we have to send the best of our young surgeons into the aneurysm business and intervention of aneurysm and so on. And so I think that's and I had a discussion with Tommy Walter on the topic. I don't know where, I say the best young people have to stay in the operating theater and do surgery because the best will be needed for the future and then not so good. So I asked those people, who of the young should go into a TAVI program? Maybe the not so skilled ones and smart ones. We need the smart ones, of course. I don't know whether we need the technically best ones, because we don't have only best ones. We have most of them are average. Maybe I'm average too, so I don't know. But statistics says we have average. So I have no idea who should go in training in the future in a TAVI program from the surgeons.
I'm afraid, Michael, we don't have the luxury. Do you know why? Because we don't have residents anymore. I mean, I don't know what's the situation in your country, but here we're struggling to get residents. I mean, in our hospital, we do 2,000 cases a year. We have one surgical resident. Can you imagine that? In the past, we used to have about 8 or 9. So how are you going to find the good surgeons? How are you going to develop good surgeons? Where from?
To find good surgeons, you have to develop them, and that's the
okay. You have to attract them.
Because they are not trained, because the people are only busy doing 2,000 cases instead of doing 1,800 and trains in new generation. Because this is luxury for young surgeons. 2,000 cases, and only one trainee in this is the best place ever. You should have 20 for this number and train them. So I don't know the answer, of course. But
Dr. Bananas.
I think it's we have to avoid to get into a problem like a nature selection, because if we don't offer the young people perspectives, they will not come. And of course, if they see that they don't learn something, they do not stay. Things that we have to offer them the opportunity to learn something new, but also we discussed a lot about that. I think that the best surgeon should know everything. Should know TAVI, should know aneurysm, should know heart failure, the basics, and then specialize in a topic. That's my opinion.
What's the
20 years to work.
But what's the definition of the good surgeon? You're not born good surgeon. You are trained to be a good surgeon.
Well,
you see, I don't think that it's somebody's born a talent to be a good surgeon. I mean, you get practice, and practice makes you perfect. That's the idea. That's how to go. But when a young surgeon or a medical student says that there's no wage, I'm going to spend 7 years, and after that, where I'm going to be employed? There are no jobs, I'm not going to get paid. Of course, they have different options. They do other things.
But there is also a change in mentality. There are also law changes.
Hopefully.
If you have to work 48 hours, then
How can you have a training with 48 hours?
Just one comment. The problem is that we have a lot of randomized studies that are going on with the TAVI. And practically all of them are industry sponsored. And we know by the literature that when a study is industry sponsored, you have a high possibility, around 90%, that the result is favorable to the industry. There is no way. This is $1,000. And you showed a slide where it was a lady that was a director of the
New England.
And the problem is the connection between these big journals and all the industries. That you remember the EVERS 2. EVERS 2 is a scandal. But this was published in the New England Journal of Medicine and brought to the widespread use of the mitral valve. Perhaps you remember that the partner study on inoperable patient TAVI versus medical treatment, that is by definition is a nonsense. But anyway, this study was a big hit because inoperable patient TAVI is by far better. So he started to use TAVI in this. But perhaps you don't know, at least I didn't know, and I realized because I read the paper from the FDA, that this study, patients were still enrolled after the study was finished and published. 1/3 of the global amount of patients, a similar 1/3, were reported to the FDA. Strangely, the FDA showed that this data was exactly the opposite. So the medical treatment was better than TAVI. So my question is, who's decided to cut the study in that specific moment? This is something that we need to know. I don't think that everything we know is really true. Because do you think that an industry will lose $1 billion+ just because one patient had one stroke more or less? This is the question. You said something true. We have not to fight the cardiologists. We have only to show our results. We have to fight the industries. And believe me, this is a war we will never win.
Anyway, I'm afraid we have